because people are going to get on.
Okay, no problem.
Arun, if you wanted to introduce Michaela, you can go ahead.
Okay. So everybody who's on here, I'm going to give, Michaela's going to tell you her titles, but Michaela and I have been friends since 2005. I was a fellow, clueless about anything ultrasound, and Michaela was a fourth year medical student at UCSF. And she got to spend 1 month in this random division that was completely a mess. And Michaela knows how much of a mess it was. And
No, it was
we
great.
became friends. And she really wanted to come to Highland. We really wanted her. Everybody in the department was like, she is going to be such a rock star that she said, peace out to Highland and went to New York. And so we've been friends since then. And she's an extremely gifted educator. And I'm going to let her tell you where she's at right now and continue on.
All right. Let me see if I can share my screen here. Thank you for that introduction, Arun. So I actually live overseas. I live in Namibia, which is a little unusual. And I go back to Los Angeles periodically to work in the emergency department there. But I'm going to be talking about local anesthetic systemic toxicity. Hopefully you can see my slides. Is it showing the whole slide for you guys? Okay, perfect. So Arun told me a little bit about a couple cases at Highland, and I was really excited about it because I feel like this is something that we always talk about, but in my world, it was like, oh, it never really actually happens. And I was like, if it can happen at Highland, like the mecca of emergency ultrasound guided regional anesthesia, then it can really happen anywhere. And I was kind of like, let's talk about it. So I'm going to start with one of the cases that he first told me about. So this is a 66-year-old gentleman who had a history of hypertension, cirrhosis, and used alcohol daily. And he was actually presented to a community hospital after falling off a bar stool the night prior. And he was found to have multiple minimally displaced rib fractures on CT, which you can see in the X-ray. His vitals were just notable at the community hospital for hypertension, but otherwise looked pretty good. And because of his injuries and age, they wanted him at Highland, the trauma center. So when he arrived there, his vitals looked considerably better. And just to give you a sense of his size, his weight was 68.5 kilos. And with his height, that came out to a BMI of 21.7. And at Highland, they have an emergency medicine resident on the trauma service. So that person admitted the patient and decided to do a left erector spinae plane block at the 9th thoracic level to control his pain. So this was done with ultrasound guidance. And within the note, the resident mentioned that they aspirated for blood and didn't get any. And then gave a total of 30 cc's of 1% ropivacaine, pausing every 2 to 3 milliliters, and essentially put that in the proper plane. So we'll just take that as it is. About 15 minutes after this block, the nurse called the physician because the patient's vitals had dramatically changed. His blood pressure was now 223 over 122, and he had a narrow complex tachycardia with tachypneic, and the SAT had decreased somewhat. The patient really didn't have any symptoms. He said he was alert, no dizziness, no perioral numbness, no metallic taste, and said he was actually feeling really good. His pain had decreased from 8 out of 10 to 0 out of 10. So they gave a bolus, and just like the rest of us, they reached for the ultrasound. There was no pneumothorax, and the echo looked, without a cause for these acute symptoms. Here's the EKG that was done, and it was just a narrow complex tachycardia. So at this point, the presumption was that this patient had last, and they immediately gave 100 milliliters of the lipid emulsion over 2 minutes, and then gave the 15-minute, dose after. And then the patient's vital signs improved. His rib pain, of course, returned. Just looking at this case, there was a dosing error. So when you think about 30 cc's of ropivacaine, that's actually 300 milligrams. And when you calculate his weight-based limit, this is well above that. And then if you actually consider what his lean body weight was, the dose is even less, it's about half of what he was actually given. So clearly this was an error in dosing, but there's a lot to unpack here. And I think it's just good for us to talk about this. The last thing is that this guy was 66, and a lot of people say at 70, you should start decreasing the dose by 10 to 20%. But that's kind of an arbitrary cutoff, and you could certainly think that this person's going to be at higher risk for last just based on his age. Now, I mentioned he was like a regular alcohol drinker. When it comes to liver disease, it usually doesn't affect the initial dose, but if you're going to give people continuous dosing, they don't clear the local anesthetics as well as someone without those comorbidities. So this is just some of the outline of what I'm going to talk about. First, I'll just define what LAST is and talk a little bit about the incidence of it. We'll review the clinical presentation, talk about ways to prevent it, identify it, and treat it, and then we'll kind of talk about some systems approaches to minimizing the risk of this. And then I think I'd really love to get more out of the group in terms of what we would do as a department, a community, in terms of managing LAST. And then I'd love to hear more about everyone's experience. So in terms of the definition, it's a life-threatening complication of local anesthetic use. It has cardiovascular and CNS effects. It's thought to be from sodium channel blockade, but it might also be that potassium and calcium channels are implicated as well. Most of these cases are from regional anesthesia, but really it's been documented in all forms, even just topical local anesthetics. So when you talk about LAST, there's a real continuum. And if you're talking about a major LAST event, it's cardiac arrest or seizure. Sorry for that typo there. Minor LAST events are much more nebulous. So those are things like perioral paresthesias, tinnitus, dizziness, metallic taste. And when you think of how often this happens, we really draw from the anesthesiology literature. So in about 1,000 peripheral nerve blocks, there's a range of what they estimate, anywhere from 0.04 to 1.8 major LAST events. When you're talking about minor LAST, in our case, the incidence of that is much less clear. And when you talk about the emergency department, we don't have any even case reports of this. So we really don't know anything about the prevalence of this in our own environment. And then I think this is something to really focus on, is because when I learned about LAST way back in the day, we really focused on immediate LAST, and that was from venous injection. So all along, we learned techniques to not inject directly into a vessel. And that is immediate LAST, and that's what happens within 5 minutes of your injection. And those are the things you're looking for on the monitor immediately. But there is a risk of systemic absorption, and that can happen even up to 60 minutes after injection. So that's going to have a delayed presentation. So you want to really kind of separate these things in your mind, because the strategies we use to decrease LAST don't apply to both of these scenarios. So just to review the way this presents, because it is quite nebulous, you can have very general symptoms like nausea, vomiting, shivering, and dizziness. And then when you think of the CNS effects, there's non-specific things like the tinnitus, perioral numbness, metallic taste, vision changes, dysarthria, things like that. And then you can have excitatory CNS effects, anxiety, confusion, agitation, seizures, and then later on, depressive effects. So people can become somnolent, their respiratory rate can go down, and they can have a frank coma. And then with the cardiovascular, you also can have this early and late presentation. So early, like in our case, you can get hypertension, tachycardia, and then later on you can get hypotension, dysrhythmias, and then full-blown cardiac arrest. So it's very broad, and then there's immediate and delayed. So when you think of like how we can mitigate the risk, I think we're all pretty familiar with the injection technique. So using ultrasound guidance, I don't think any of us is going to do a block without that. But obviously that helps you locate your needle and where you actually place it. And then I think everyone's familiar with the concept of hydrolocation with saline or even the local anesthetic. But the benefit of using saline is that you're not adding additional anesthetic to while you're like just trying to figure out where your needle is. Obviously, I think aspirating prior to each injection is something that you learn like early in med school when you're just learning how to give local anesthetic. But there's definitely a possibility of false negative aspiration. Like if it's a small vessel, it's going to collapse under negative pressure, and you could actually be injecting directly into a vessel. And then this is something that I think is really critical and not emphasized enough, but the idea of pausing every 30 seconds. I don't think a lot of the people I know who do blocks in the emergency department routinely do this. Like every 30 seconds, every 3 meals, pausing 30 seconds to see our patients developing any symptoms. Because if you think about that, like for the 30 cc's that was injected, that would be like over 5 minutes, which is a long time when you're an emergency physician. And then using epinephrine, so the epinephrine has a couple of roles, but in the context of this, it would be that the initial injection into a vessel would actually cause like a change in heart rate and blood pressure within a few, like 30 seconds. So these types of things are really only directed at direct intravascular injection and not this delayed systemic absorption. So in terms of the things that we can do for that, obviously using like the lowest dose possible is the best thing to do, but that's not always feasible. But when you calculate your maximum dose, you really should, like most people actually in the anesthesia literature think you should use lean body weight, which I don't feel like most emergency physicians do. And then you want to account for extremes of age. So very young people and very old people are more sensitive to toxicity. And then there's a few comorbidities to keep in mind that should make you decrease that max dose. And then when you think about choosing an anesthetic, that's quite important. There's 2 things to think about. One is cardiotoxicity. And so the most cardiotoxic drug that we typically stock in our ED is bupivacaine. And then lidocaine is like the least cardiotoxic. I can tell you, LA County, we do not have ropivacaine in our ED. So we're kind of, if you need a long-acting agent, it's not, we don't have the safest option, to be honest. And then the other thing to think about is the cardiovascular collapse to CNS ratio, which is just a way to, it's essentially like the dose required to have someone have cardiac arrest compared to the dose required to have seizures. So having a larger ratio is like a safer profile drug. And luckily it follows the exact same algorithm as the cardiotoxicity, where lidocaine is the safest, et cetera. And then in terms of using epinephrine in the context of this delayed toxicity, it causes vasoconstriction, so it kind of limits your systemic absorption. So it helps in that regard as well. And in these large volume plane blocks, like the rector spinal plane block, it's been proven that it like decreases the maximum plasma concentration and the time to that concentration. So really critical when you're putting a lot of volume in. Just a plug for this is what I use to calculate my max dosing, but it's a free app and it allows you to select whichever, you can use multiple local anesthetics and select whether you're using epi or not. So this is just an example of if you were going to use lidocaine for maybe the skin and bupivacaine for the actual block. And then you put the percent in, and then it has you put the patient's weight in. And then what I love about it is it actually reminds you of the things that affect your ability to like clear local anesthetic out of your body. So it kind of is, it allows you to kind of like mentally offload some of this information and remind you it's a cue. So I put this slide in here because I think it's really important that we talk about like consenting our patients. And I think the ideal patient for a block is someone who's like alert and able to like understand what they're about to undergo. And they really need to be told the symptoms. Like you need to warn them about the metallic taste and like anxiety, and just say, hey, during this procedure, I really want you to give me feedback. If you're feeling these things, I need to know. And then obviously the patient's on the monitor, which is essential during these large volume blocks. So not just having a cardiac monitor, blood pressure, and pulse oximeter, you want to have an IV ready to go in the event that that this patient goes down the path last. And then having oxygen and a crash cart is also critical to kind of being prepared for everything. So the mainstay of treatment is intralipid, and it's thought to basically bind the lipophilic local anesthetic. And I put this up because I think it's just a really clean checklist. And this is what Highland actually has on their block cart. So it gives you the algorithm of like exactly how much lipid you should be giving based on the patient's weight, their initial dose, and then the 15-minute dose. And then seizures you treat with benzos. And then there are some nuances with ACLS if the patient does go into cardiac arrest. And so it's a nice cue for that. So I think when you talk about decreasing the risk in our personal emergency departments, I think there's certain system changes that you can think about. And I'd love to hear if other people have ideas or things that have been successful. But one of the outcomes of the case that I described was stocking more dilute forms of anesthetic. So at the time, bupivacaine 1% was stocked in the ED, and then they switched to 0.5%, which makes a lot more sense. I'm sorry, ropivacaine. I totally said bupivacaine. Which just makes sense, but also just like cueing patients or providers to give saline and dilute things. And then, you know, I think having some sort of standardized monitoring requirement, or at least kind of plan within the emergency department of like how you do this. I mentioned the consent process of like including last symptoms when you educate the patient, and then including that on the actual consent, I think would be a helpful change. And then, you know, I think the big miss in this was that the doctor didn't calculate the maximum dose. And so, you know, I don't know how to require people to do that. And I'd love to hear if people have ideas about that, whether you document it or just there's something to trigger you prior to doing it, like what is your max dose for this patient, so that there's some real awareness of that. And then I think having intralipid in the emergency department is just an amazing thing, so that everyone's ready. And then having the last checklist so that there's not confusion in the event of this unfortunate rare outcome. And then I think, you know, to me, there has to be some quality assurance. And so I think it would be really great if every emergency department like kind of regularly reviewed the blocks done in their emergency department to see, you know, where are we falling short? Like, are we actually overdosing in some cases, or, you know, where are the opportunities to improve the outcomes before there's a, you know, a bad case? Because I think it would be interesting to see, you know, are people giving the wrong dose? Are they not pausing every 3 cc's? And then just things that I think would be helpful to cue people is just like, this is how you calculate max dosing. Like everyone should have some way that they do it, be it, you know, an app on their phone, but just some consistency. And then a reminder to use epinephrine, because I think a lot of people don't always think of that. Reminder to use saline, and then to pause during injection. And then I think it's a really great idea to like simulate a case of last in the department. It doesn't have to be so hokey, but even just asking your nurse, like, how do I get the intralipid, and timing them, like how fast does that even happen? Because if you find out that it's like stocked far away, it's really gonna end badly if you actually have a case. So I think like what do we do when this happens? Like I think it's helpful to have like a quality assurance or an M&M process where you kind of like review the case and see where the missteps were. And then I really think it would be great if we had like some registry where we could even put this together to have a better sense of what's actually happening, like what blocks are these happening in, and what were the errors. So I just wanted to, I actually have a list of questions I thought it would be. Let me stop sharing my screen here. I have a few questions I just like wanted to poll the group on. So I was thinking you could just like raise your hand if have you had any last cases in your department that you're aware of? Okay, so we have like 2 people, which is like not too many. And you can also raise your hand if your screen's not shared. What about epinephrine? Like, is that something that your providers are routinely using? If yes, you can maybe do thumbs up or thumbs down. Yeah, I mean, yeah, I think it's my experience is that we aren't routinely using it, and I'm not really sure what the downside is to using it. To me, it seems like we should always be using it. And then someone had another with bupivacaine and erector plain block. And I think it's interesting because if you read up on ESPs, people say that it's a really low risk block, but now we have like within our little group here 3 cases all with the erector spinae plain block. And I mean, it's a very high. Yeah.
Can I say something? So this is something that when I
Please.
was at Astra this year, this really kind of blew my mind a little bit. I don't know if everybody was at this talk as well, but if you guys have ever read the anesthesia literature, Vincent Chan out of Canada writes a lot of this stuff, and he's a very smart guy. He's an engineer by training, and he held a lecture where he asked people a large group, who used the erector spinae and who thinks it works. I was kind of shocked by that question because I've used it so often. And what he was trying to get to the point was that he believes, again, based on a lot of literature, which he has, and I'm going to bug him about this, is that the erector spinae plane block is actually, you're just depositing anesthetic in this plane, and the venous plexus is absorbing it, and that's causing the block, which is a really interesting concept. He believed it's kind of a bullshit block, and a lot of people in that room believed it as well. And so the concept that using bupivacaine in that space with high venous absorption is probably not a good idea. Because of this episode, we really have moved to not using bupivacaine ever in the ED as our anesthetic of choice, especially for planar blocks. I think for simple forearms, but for planar blocks, we have moved away from it. And the reason we had a 1% ropivacaine is because our pharmacy keeps going back and forth with supply shortages of ropivacaine. So sometimes you have 0.25, sometimes you have 0.5, and sometimes you have 1%, which is really unfortunate. We can't get around that right now because of shortages of ropivacaine to our pharmacy. But I think the concept of using bupivacaine for erector spinae, we should probably think of it, or serratus, or TAP, and especially the thorax. I think more of the thorax than the abdomen, because there's such a high venous plexus there for warmth, for keeping your body core temperature normal, is probably a bad idea. So it's an interesting concept. I haven't dug into the literature, but it's really a smart guy saying probably some smart stuff.
Arun, have you run into, so at SAM this last year, there were a ton of little side conversations about crystallization with ropivacaine and Dex. That's because I ended up going through our central pharmacy so that we'd have 0.5% ropivacaine available for all the planar blocks. But then the issue now has been like with the transgluteal sciatic nerve block, if we're going to add Dex to it, it's like a weird messaging back to say, hey, there've been a lot of case reports of ropiv and Dex crystallizing before you block. Have you run into that at all?
it's in the case report literature. We have moved it away from it. There's a nice piece that just came out, and I can send it out to the group, that talked about using really micro dosing of Dex with ropivacaine and being safe. It's like literally like it's like a 1/100th the dosing and showing the same efficacy. I just don't know the answer to that. It's a really good question.
I spoke with some of my anesthesia colleagues, and they mentioned that it seems to be a time-related effect. So they will store them separately, and then they'll combine them right before the block, as long as it's within about 10 to 15 minutes. They say that the risk of crystallization in that scenario was pretty low, that they continue to use both together.
That's been my experience as well. I also just shake them up so the bubbles show up when I do the block. And I'm just kidding.
Yeah, but I think it's a really good point, Joe, and I don't know the answer to that, but I think that I'm going to ask some more people. I've read enough of these case reports where you see it. I just haven't had it. We used ropivacaine with Dex for years and did not have any problems with it. Maybe we weren't noticing it. I don't know. But I think it's a really good point. I don't know the answer. But I think the concept of a lot of these blocks in the fascial plane or just venous absorption is a really interesting point. Again, I'm gonna have to dig into that literature as well.
Can I ask a quick question? How do you determine that it's not like a vasovagal episode? Because I had an interscaling where shortly after the block, we had like a hypotension and bradycardia. And at the time, this is like a year and a half ago, I wasn't as involved with you guys. I didn't recognize it as a last event, and it probably was. I thought it was a vasovagal event. Do you have any advice or recommendations to tell the difference, or just to always assume it's last? I don't know.
I think you would just have to assume that the worst. I mean, because the vasovagal symptoms would overlap so much with last, right? Like the nausea, maybe you would like, obviously the vital sign changes overlap, but I don't think there's too much downside to giving the intralipid. It's not expensive, and yeah.
Yeah, we had the exact same case, and it was after a rectus spinae also, but it was 72 minutes after we gave the block. Yeah, and it was in a I know, but it was in a geriatric patient. We blocked him, kind of pieced out, went to my section, and then I get called over well over an hour later saying that the patient's unresponsive too. And then when he came to, the family says, oh yeah, he vasovagals whenever he has anesthesia too. So, we still pushed the intralipids, not knowing that history, and he was a little hypotensive, but that would be a case report, but I was not entirely convinced that that was caused necessarily only by the really low dose of ropi that we gave him. It was, I think we were not even at 60% of the maximum dose.
Wow.
So, yeah.
For Arun and Joe's article that you guys published, what was it, last year, and you recommended that over 10 cc's, you should have a 60-minute observation period. Does these couple of case reports of like 70 minutes or so on, does that change what you would recommend?
No, I think it's standard. I think what we've been doing is high volume, and Joe can give me the exact numbers, but for high volume, this is a conversation we had. High volume blocks, right? Thoracic, abdominal, anything that's high volume, you should probably keep on a monitor for 30, 60 minutes. It's really a soft number. Is that right, Joe?
Yeah, I don't think we listed, I think we just said more than 10 cc's. So that's what we considered a high volume. And then we said truncal or anything close to a large vascular structure.
Yeah. And that's just trying to be as conservative as possible. Again, I don't think that the goal of this conversation is to scare people and make everybody freaked out, but I think what the goal is for us to be more educated on it, because when we get bogus from our anesthesia colleagues or from other people, we should be the experts on this and at least be able to argue the points, right? Rather than, oh, he was just anxious and I walked away and then something bad happened, right? Just sit by the bedside, wait 5 minutes, talk to the patient. Like, I think just having a little bit of alert. Again, both the cases that were done at Highland were because of a resident not doing safe local, a resident pushing too fast. I mean, these are these are errors that we have, and I forget that every year we have, we have to really reiterate these points of safety. And I think it's so easy to just forget about the fact that these people have no idea what they're doing until, because every resident is a 2 right now wants to do rectus spinae all day and do serratus all day. They'll walk around. The trauma team will do so many of them with our resident. And it's kind of a little scary to me.
I have a quick question for the group. Are most people using lean body weight? And if so, has anyone actually like implemented that with their EMR to just like generate that underneath the BMI? Because I feel like that'd be a nice QI thing. That'd be just easy.
Unless you dunked them in a bucket of water and weighed them. I don't know if you get that data.
Yeah, I think there's like a calculator that you can use, right?
Really? Oh, I didn't know that. I didn't know that.
Yeah, I was just curious.
Yeah,
if people are using that.
there's definitely a calculator, and it would be so nice and should be easy to just add it in. But I don't know of anyone doing it. And to my knowledge, people don't actually use lean because it's a kind of an annoying calculation. Yeah. So who else has intralipid in their emergency department other than Highland? Okay, that's great. That's really good. And then do you guys all have like some type of departmental policy to monitor, like on when you monitor these patients?
Yeah, we have a written
There's
policy.
kind of like 50-50, it looks like.
We have a written place just because we had what was happening. And again, this was, again, our fault for being, trying to push things, was we were having our mid-level providers doing blocks in the fast track area, which was just a bad idea. And they were doing planar blocks and just like, this is a bad idea. And residents doing planar blocks without monitor. I mean, it was just, I had to clamp down. I got a lot of pushback from people saying that I'm being a kind of an ass, but I just think it's really dangerous because one of these episodes that are not monitored can really lead to some downstream huge problems.
Yeah.
Arun, remind me if we've got it in all of our Pyxis now, because the half-life of intralipid, you don't have to store it. It can be fine at room temp for like years on end. I've also worked at places that had it in the block cart. If you could get a locked cart so that it just rolled around with everything else that was happening, which was pretty nice.
Once you have the block cart, you have a block box. In each block box, there's intralipid. So while they pull out the box and then they go do the block, there's an intralipid sitting there with on top of it wrapped around how much to push. And I just teach the residents just push 100 and call somebody, right? But it's we try to make it simple, but it's still a work in progress. I wish I had Rob was there or whoever's come to Highland. I mean, it's good, but it could be better.
And then does anyone have like any tips on like how to make providers actually calculate the dose? I mean, I usually I was thinking, go ahead.
Sorry, I usually make it part of the consent process where like I say, like, there's this local anesthetic systemic toxicity, which is a possible risk. I believe that this is a low risk because your maximum dose is this number and we're going to be using this number. And so it's just incorporated pre-procedure into the consent process. So I tell my residents and other attendings that it should be incorporated into the note as part of the consent.
I think that's great. Because I don't even think people just document how much they give. They don't even document what the max dose would be based on the weight. That's been my experience, is that it's just not, like, even if you get someone to do it, they're not documenting it. So I love the idea of putting it in this consent. And then what about pausing? Does everyone feel like people pause that often when giving these large volumes? I think that's like, anyone with strategies about like how to get their providers to do that?
I typically do I want to see like 2 quick or like 2 slow pushes and then aspirate, and then 2 slow pushes and then aspirate. So like it's like when I'm in the room with them, and most of the time I'm the one that's actually pushing the meds, and it's just like that's how I sort of belabor the point.
Yeah, I think these are all really good points. The hard part is that once your block program gets a little bigger, you're not going to be involved in most of the blocks. I mean, I'm only involved in the blocks that I do, right, with my resident or when I'm teaching. Every other day right now, somebody's probably doing a block, and it's going to be that in one of our attendings. And so it's like, how do you get that message through? You have to, I think this has to go to like QRC and like lectures at conferences and be very structured with your residents, because my residents will do stuff you're like, what are you doing? Like, I'll walk in the room, I'm like, what's going on? Even though I think we try to have a pretty strong block program, I think that there's, it's, what happens in emergency medicine. Yeah, bros like to push anesthetic quickly.
And then do you like regularly review all the blocks that are done? Is there some like way your divisions kind of can identify possible problems before there's like a horrible outcome? I'm just curious, is that like part of everyone's program? I guess thumbs up if yes, or. That's good.
I think because we don't have a huge number of them, we,
Mhm.
as part of our usual QA of QPath, any procedure as part of QPath that's not a peripheral IV, because we stopped caring about a lot of that, is kind of incorporated into that process. So I think by
So do
default,
you,
Yeah, like, we're always going to review every block because it's still a relatively new, exciting thing.
so you open the chart and see like exactly how much was given and like the patient's outcome essentially for each of the blocks done.
I think we will.
I think
I'm just curious.
the people in this room are the people doing the blocks. So we already know that information at the hand as
That's
well.
true. Yeah, that's a good
fine.
point.
That's how you build it.
It's just a gentle plug. I'd also, to your original point about the registry, like we do it already because of the nerve block registry, which is going to keep recruiting more and more people. But so every block that gets put into that gets reviewed and seen if there's any signs of blast. So just a gentle plug. I know Nicole and Andrew's just hopped on. But they're like, we're going to keep recruiting more and more sites for the National Registry for the nerve block, for nerve blocks, just so that we can keep building out this sort of database. And I think that for us at least serves as our QA sort of 30 days out.
And I think that this conversation as a group really strengthens what we're doing. Anesthesiologists don't do this. There's no anesthesiology group that meets regularly, that talks about their errors, that talks about their successes, and collectively, right? Like, hey, Rob, I had this case. What do you think of this? Or, hey, Arun, I had this case. How would you get around it? I think that totally elevates all the boats, right? And makes us way stronger as a group, because there's going to be headwind when it comes to departmental stuff. And I think this is the only way to get around it.
I have a question for the people on the group. Our hospital has a lot of boarding issues, and finding a telemetry room or a room with a monitor sometimes takes an act of God or STEMI himself. And one of our most common blocks is on hip fractures, and those almost never get a monitor room. Sometimes they don't even get a room; they just get put in the hallway. Do you guys have like any considerations in terms of like weight-based dosing or anything to like, or is it just a standard, like if you're doing a plain block, large volume, they're on the monitor? Because our division talked about it, and there was some agreement, some discussion about whether or not if we ensure that we're under the maximal dose, or if we're under the maximal dose, that maybe these patients don't even need a monitor at all, as long as they're able to tell us whether or not they have symptoms, if they're aware, solely because of the fact that our boarding has gotten to crazy situations. So I don't know if you guys have foregone monitoring in that, or everybody that gets a large volume block gets monitored regardless of location, weight, all that.
So Trent, I worked in a residency in New York, and I God bless you for being there. But all of our patients are on monitor in a room. I don't know if that's me or that's other than fast track, and I can even get a monitor in fast track. So I don't know if that's an issue at other places. I like to hear what people say.
We don't have monitors everywhere. We have to physically move patients around to be able to get patients into rooms and or hallway monitors for fascial iliaca blocks. I mean, we've done blocks in hallways all over the place, and I consider ourselves pretty resource heavy, which is interesting.
Hey, Andrew, you can't, like for me, if I'm going to do a block in a hallway, I can get a monitor, like a portal monitor placed on the
Portable.
there for half an hour. You can't do that?
Not all the time. We don't have enough. It's interesting. We're covering 40 to 60 boarders at a time right now, and that takes up our rooms. So 80 to 90% of our patients are seen in the hallway currently.
Wow. Yikes.
We've done portable monitors in the hallway, or did a flipperoo, hey, you get out of this room for an hour, and then we borrow somebody else's room.
That's what we do. Yeah.
Yeah, that's what we've started to do for some more of our truncal blocks or blocks that need more monitoring. We have some portable monitors, but they often don't go anywhere, and it's just a frustrating experience. But I just wanted to see what the group does when they're in a really bad boarding situation.
Well, I guess my question would be,
go ahead, Andrew.
No, Nicole. I just have a comment.
Yeah, the issue with portable monitors is like a lot of the time we'll get, if we get one, you know, the resident will do the block and then I'll ask them 20 minutes later, how's the patient doing? Nobody's looked at the monitor. So it's kind of like a false sense of security, right? Because I'm like, are they breathing? They're like, oh, I don't know. I'm like, go check. Because it's not on my board, right? Like I can't see it like projected above me if it's portable. So it's like a little bit of a false sense of security, but at least somebody like can see a wide complex tachycardia or something, maybe.
The problem that hurts us is that sometimes it prevents us from doing the block, or like somebody who feels comfortable doing the block was on shift, and then because it takes so long to get a monitor and or a room, they go off shift and therefore the block is lost. That's the frustrating part we have, at least.
Yeah, we're in a similar boat here at our trauma center. When we have blocks that need monitoring, I got to move them to a trauma bay or something and take up one of our 4 trauma bays for about a half hour and keep them on a monitor, which, you know, they should be on a monitor for longer, but it's give or take. But
yeah,
The only reason I brought this up is it's just we had discussion before on this group about the utility of monitoring frequent vitals and all that, and although I'm all for monitoring for a certain period of time, we're talking now about local anesthetic toxicity being after 60 minutes. So I feel like this runs somewhat in counterpoint to our earlier discussions, maybe rightfully so. Maybe here at Hartford, we're being a little bit too cavalier about all that stuff. So
I think it's just being cautious, right? I mean, again, I think that there's always play in this. I just think you have to write a protocol that works for your hospital and your department, that is accepted by your leadership. Because if you say that all patients should be on a monitor for 30 minutes and then the patient is on a monitor, I think that's the trouble, right? We were having problems, people doing electrospinase and fast track with no monitor. And I was like, I just have to not allow that to happen. So I think finding a protocol that works, it doesn't have to be a national protocol. It can be just your own hospital protocol. And I'm sorry, I know you're in Hartford, not in New York, but I think it just can make more sense. And we just have the portable monitors and we have a few of them. So we just stick it on and let it sit for 30 minutes.
I think that most of the cases do occur within 30 minutes. It's just there are these prolonged ones. So I think if you are in like a situation where you have so many people boarding, 30 minutes is better than nothing. 60 minutes is ideal, but we all operate under less than ideal circumstances.
Yeah, I find that challenging with like the transgluteal blocks for sciatica, right? Because it's not only do I not want to monitor them for an hour, I don't want them in my ED an hour after I do the block, right? Like if you can walk, I want you out. And so I find it really challenging to ascribe to those good protocols.
That was kind of deliberately why when we wrote it, we left it as sort of nebulous as like 30 to 60 minutes at least. And then we also used the like truncal and near large vascular structure, which for the transgluteal, right? You're like kind of in the middle of nowhere, which that was the only other one that we really discussed before we like finalized those kind of numbers based on our conversation with some of the anesthesia colleagues. But like it's tough. I mean, everybody's got a little bit different thing, because I'm the same way. It's like once you can walk, if your pain's better 15 minutes after the block and you can walk, ta-ta. But yeah, it's tough.
Yeah, I mean, there's a lot of things that we write down that we, obviously protocols are protocols. You want to keep it clean, but we've all had those cases. So I think that's okay. I think it's just okay to have, but I think individual departmental protocols are important. And I think you can adjust off the protocol that we've written to make it your own and make it shorter, and make it monitors and portables and whatever you want to do, right? However game you want to play it.
Correct. As long as you can show that you have some sort of a protocol. God forbid there is a bad outcome or an undiagnosed loss that went on. the first thing that's going to happen is an RCA, right? And the first thing that they're going to do is they're going to say, okay, the ED gets to not do blocks. For us, we made it 60 minutes just for the sake of showing that we're keeping our noses clean, right? So, you know, as long as you actually, even if it's 30 minutes, as long as you have it in your policy saying you watch them for this long, and then the administrators can do whatever the heck they want. But it's just a matter of showing that you are following some sort of guidelines.
There's
But
a
yeah, I
little
agree.
bit
If they're walking around, that's annoying.
with respect to the transgluteal sciatic nerve block. Is anyone doing D5W? Some of us have moved to that to do, which sounds like complete made up voodoo. But there's some evidence that if you use D5W for transgluteal sciatic nerve blocks, that it works just as well. And obviously, you don't have any last side effects. You don't need an IV. You don't need a monitor. You just do a shot and you can discharge them.
Yeah, it's supposed to decompress the nerve just as well as using using a Lido. So I don't know. I haven't tried it. I've seen that data though. I'm very curious.
I've tried it twice. One worked great and one didn't work so well. But.
Yeah, but I've had transgluteal sciatic nerves blocks that haven't worked very well. So I think it's really interesting. It's an interesting idea. I think we should investigate. I know that the San Diego people are really excited by it, and you guys are kind of pushing it forward, which is great. I think more safety thought processes and more people thinking outside the box really can make this grow better.
I'm going to share with the group real quick, just something that kind of came out of our QI or review of the last case that we had is even though the provider knew the correct dosing and what medications he wanted to give when we had the episode of last, we found that the nursing staff didn't know. So I like that simulation case a lot that you were recommending, but something else we did is we just made a last protocol in our EMR. So it's like an order set. You just hit it and then everyone knows what you have to give.
Great idea.
That's a great idea.
Yeah, for our order set that we designed with our pharmacists, it's the dosing of whichever local anesthetic you want. And then as a sub menu of that order set is a last order set, which includes the intralipid first 100 cc's and then also the subsequent drip of the rest of the liter. So that's how our pharmacist wanted to do it. So if that's something to repeat elsewhere, I don't know if that's how.
Yeah, it's nice to have it pre-ordered.
Yeah, we have the order set, and then when I typically teach it, just to keep it simple, I do the same thing that Arun said, which is just 100, repeat 100, repeat 100. Don't worry about using like some of the finite points if you're out in the middle of nowhere and you just needed to be able to do it quickly. But at our sort of like mothership, we've got the order set already in place.
Mm-hmm. If we're done, could I do a personal plug and then we can end it? Is that fine, Dan? Do you have any comments for Dan? And thank you again, Michaela. I mean, really, thank you for great talk. I think hopefully getting all of us to think. I think, Duke has a nice video on last as well. It's really well done and really clean. He always does great stuff. For ACEP this year, again, this is a personal plug, and if you guys are interested, I'm going to be making Blockhead t-shirts. Really simple with a little insignia. I purposely don't want people to know what it's about. Kind of want them to look at the t-shirt and be like, what the hell is that? And while you guys are wandering around ACEP, and exactly, that's right, Joe. And kind of keep it so it's kind of a cool group of kids that they're not invited to. Is all purposeful. If you guys want one, please email me. I think I'm going to try to make it under $30. I'll hand it out at ASAP. It'll just have a cool logo and it'll say Blockheads 2023. And then we'll be updating that logo if you want. If you can't afford it, Trent, I'll pay for it. Just send me your, I know in Connecticut it gets expensive. But if you guys want one, just email me and tell me your size.
Awesome. Thank you very much, everyone.
Yeah, thank you, everyone. It's great to hear your ideas. Bye-bye.
Good luck.